In this session at Medical Sciences Made Easy by Naftali Muhumza, we want to discuss on receptor families and their mechanism of action. How, when the drug has bound to these receptors, how do they bring about pharmacological responses? So as we get started, we always remind you to subscribe so that you can keep updated whenever we release videos. And there are only 4 receptor families where we have ligand-gated ion channels, we have G protein coupled receptors, we have enzyme receptors, and nuclear receptors. So we're going to begin with ion-gated, what we call ligand-gated channels as number 1, ligand-gated. So these channels are used, as the name suggests, that they are ligand-gated ion channels. That whenever a drug binds to this channel, they allow influx of sodium ions, because we know outside of the cell is always positively charged, outside with sodium ions outside then inside we have the potassium ions inside the cell. So, and even outside we find there's chloride ions present within the extracellular fluid. So if the drug which binds to cholinergic nicotinic receptors, so this ligand-gated channel, the drugs that act on them are cholinergic nicotinic receptors. So a drug such as nicotine, which is most commonly found in cigarettes, acts via these ligand-gated channels, and other drugs like barbiturates, which are anticonvulsant drugs, which work via GABA receptors. So if the nicotine comes, if this is nicotine, if nicotine drug comes and binds on this receptor at this point, this drug causes the opening of the gate. The gate of this channel opens because of the weight of the drug after binding, and when the gate opens, we see influx of sodium ions. You see influx of sodium ions inside the cell, and after the gate opening and sodium ions start entering into the cell, and we know initially inside the cell it was negatively charged, but after the entry of sodium ions, it becomes positively charged. And this positivity of the charge inside the cell is what we term as, they cause depolarization. They result into depolarization of the cell. So the cell becomes depolarized, whereby inside it becomes positively charged and it can fire an action potential. That is for drugs like nicotine. But drugs which target GABA receptors like barbiturates, an example of barbiturates is phenytoin and phenobarbital. We see them when they bind to the GABA receptors, which is inhibitory. For them, they lead to what we call hyperpolarization. So for the drugs that bind on the GABA receptors, which is an inhibitory receptor, for them they result into hyperpolarization. So that it inhibits propagation of impulses, which is applied majorly in convulsing patients to stop seizures. So drugs which can do here is barbiturates, which causes hyperpolarization, like drugs like barbiturates do this, that when they bind on these ligand-gated ion channels, for them, instead of causing influx of sodium, for them they cause efflux. These ones result into efflux of potassium ions, and when the potassiums were inside, when they move out of the cell due to the opening, they cause inside of the cell to become more negative. it becomes more negatively charged. And when it becomes more negatively charged, this is the state we are calling hyperpolarization, and an impulse cannot be propagated when hyperpolarization state occurs. Then if the cell becomes depolarized in the presence of like nicotine drugs, for them an action potential is fired. So this is the mechanism of action of ligand-gated ion channels, whereby either they can result into influx of sodium ions, causing inside the cell to become positively charged, leading to depolarization, or those ones that work under glutamate and GABA receptors, for them they cause efflux of potassium ions, leading to the inside of the cell becoming more negative. And when it becomes more negative, is what we are calling hyperpolarization. And drugs we have seen are like anticonvulsant drugs like barbiturates, doing that to stop firing of impulse within the CNS. So this is what we can discuss under ligand-gated ion channels. The second one we can discuss in this video is G protein coupled receptor, GPCR. And these G protein coupled receptors, they're divided into G2. We have GS, G stimulatory, and G inhibitory. So there are three types or categories of G protein coupled receptors. Others act via G2, others act via G stimulatory, that is GS, others work via GI, which is G inhibitory. And to begin with, we are going to look at the mechanism of action of G2. If I have G2, which is a type of G-coupled protein receptor, what happens is that when the receptor is not bound to the drug, which is water soluble and large in size, this one is for water soluble drugs and which are large in size. So large drugs and water soluble drugs, they have receptors outside the cell. So, but before they bind, this G-coupled receptor has the drug receptor domain and the G protein domain, whereby the G protein domain is binding to alpha, beta, and gamma subunit. But when without a drug, it is always, the alpha subunit is always bound, GDP, that is guanosine diphosphate, is always bound to alpha subunit. But in the presence of a drug, which is water soluble and large in size, when this drug comes and binds on the receptor, this is the receptor and this is the drug, they form what we call drug receptor complex. And this drug receptor complex which is formed, it causes the conformation change in this G coupled, which spans the membrane 7 times. This one spans the membrane 7 times. So when the drug binds to form a drug receptor complex, we see it causing a conformation change, and after forming this complex, the drug the alpha subunit which is in combination with the GDP, it releases the GDP and binds to GTP. So we are going to see GDP, which was initially binding on the alpha, is released after the drug binding, and in this case, it binds to GTP. So GTP comes and displaces away the GDP, which was initially binding. And then at the long run, we shall see GDP, which is released, and then GTP comes and binds guanosine triphosphate to the alpha. And when it binds to the alpha subunit, it releases the beta and gamma subunit is released. So beta and gamma subunit are cleaved off and they move away. So we remain alpha GTP complex, and this alpha GTP complex is the one that comes and activates it goes and activates inactive phospholipase. This phospholipase is membrane-bound enzyme. So phospholipase, which is membrane-bound enzyme, is always inactive without the drug. But when this drug binds, it becomes activated by alpha GTP complex. So this alpha GTP complex, after displacing GDP, it activates phospholipase at the membrane, and after activating phospholipase, which was inactive, we are going to see that it is going to convert. Phospholipase comes and converts phosphatidyl inositol bisphosphate, that is P2, and it converts it to IP3 and DAG, what we call diacyl glycol. And these are second messengers. So we are going to see that in the presence of phospholipase, phospholipase is the one that catalyzes the conversion of phosphatidyl inositol 4,5 bisphosphate to form inositol 4,5 triphosphate and diacyl glycol. And we have said these two are acting as second messenger. These are second messengers within the cell, and the IP3, which is formed, that is inositol 1,4,5 triphosphate, it is the one that goes to the endoplasmic reticulum and activates the endoplasmic reticulum to open to pump out the calcium ions. And when there is influx of calcium ions into the cell membrane, into the cell cytoplasm, this release of calcium within the cell, it causes contractions. If it is the heart muscles, they will contract. So the importance of a second messenger, that is IP3, it goes to the sarcoplasmic reticulum or endoplasmic reticulum, causing release of intracellular calcium ions, leading to contractility of the cell, hence bringing a response. Then DAG, for it is the one that goes and activates protein kinase type C. And these protein kinase type C are the one that go around doing the work of phosphorylation, whereby it phosphorylates proteins within the cell, structural, contractile proteins, to bring up a cellular response. So this is the mechanism of action of G2, which is a type of G protein coupled receptor, whereby the drug binding to form a complex causes the release of GDP, and GTP binds to form alpha GTP complex, which activates phospholipase in the membrane, and the phospholipase converts the phospholipid type known as phosphatidyl inositol 4,5 bisphosphate to IP3 and DAG. Then IP3 causes release of intracellular calcium ions, leading to contractions, whereas DAG goes and activates protein kinase type C, which goes and phosphorylates proteins within the cell, hence bringing about a cellular response. And another type of G-coupled receptor, so this one was G2. Then this one is going to be GS receptor, whereby G stimulatory, that when the drug binds on the receptor to form drug receptor complex, which causes a conformation change in the G coupled, leading to the alpha, which was initially bound to GDP, it is released and it binds to GTP and then cleaves off. It cleaves off the beta gamma subunit away. Then when this GDP is released and it binds with GTP, the alpha GTP complex formed. Here it leads to formation of alpha GTP complex, and it is this alpha GTP complex that comes and activates the cell membrane enzyme known as adenyl cyclase. So we're going to see activation of adenyl cyclase, enzyme, which is inactive and is activated by alpha GTP complex. And after being activated, we are going to see that this adenyl cyclase, which is membrane bound, is going to hydrolyze ATP, and the ATP is hydrolyzed to cyclic AMP, which we call CAMP, and this one leads to increase in CAMP levels, and this CAMP level is also a second messenger. So this is the third second messenger. The first second messenger was IP3, the second one is DAG, the third one is cyclic AMP. And when cyclic AMP levels increase in the cell, they go and activate inactive protein kinases. This time it is type A, becomes activated, and after being activated, they go and phosphorylate. They do the work of phosphorylation. It phosphorylates proteins, bringing about cellular response of the drug. So this is the mechanism of action of G stimulatory. And the drugs that work through GS, they always target beta-1 receptors and beta-2 receptors. All of them work through GS, whereas muscarinic type 1 and type 3 work through G2 receptors. Then the last type is G inhibitory. That one for inhibition, whereby the drug which acts through GI, for it does the reverse of G2, of GS. Instead of when GI, a drug which is inhibitory, when it binds on this receptor, for it inactivates, or it does not activate what we call adenyl cyclase enzyme. And once adenyl cyclase enzyme is not activated, there is no way how we can hydrolyze ATP to cyclic AMP. So the end result of GI, the end result of G inhibitory receptor, it causes inactivation of adenyl cyclase. And when adenyl cyclase is inactivated, there is no, it decreases CAMP levels. And without CAMP, we cannot see protein kinase type A being activated. They remain inactive, hence bringing about or stopping the cellular response. So G inhibitory, they act by inactivating. When a GS has activated, G inhibitory comes and inactivates, hence reducing these CAMP levels. And then the cellular response is stopped. That is how they act. That is G-coupled receptors. Number 3 we can discuss about is enzyme receptor. And these enzyme receptors, a peculiar example is the one of insulin, which uses this tyrosine kinase. And this tyrosine kinase has the alpha and the beta subunit. These are the beta subunit of the tyrosine kinase. So when the insulin comes and binds on this tyrosine kinase, it works via what we call JAK-STAT, Janus kinases, JAK-STAT. And this JAK-STAT comes and causes phosphorylation of beta subunit domain of tyrosine kinase. And after being phosphorylated by addition of a phosphate group, these phosphate groups on the beta domain of the tyrosine kinase goes and autophosphorylates, cause autophosphorylation. They go and cause autophosphorylation of proteins within the cell, bringing what we call a cellular response within the cell. So we are going to see that when insulin binds, when drug insulin binds on the tyrosine kinase, it causes a conformation change whereby via JAK-STAT, which causes phosphorylation of the beta domain of the tyrosine kinase, and these phosphates acquired by the beta domain are the ones that go inside the cell, starts donating phosphate groups on the protein to become activated, and this insulin is able to exert a response. Another way, apart from autophosphorylation, they can also command transcription or formation of new genes. That is the mechanism of action of enzyme receptors such as insulin, and another type you can use is growth hormone. Can also do the same of phosphorylating beta subunit of tyrosine kinase. Lastly, we can talk about the mechanism is number 4, which is nuclear receptors. These ones are known as nuclear or intracellular receptors, and this one is for drugs which are lipid soluble or steroidal drugs, lipid soluble drugs, and small drugs like thyroid hormones T4 and T3. So lipid soluble drug and smaller molecular size drugs, for them they use nuclear receptors. And when these drugs come and bind on the receptor within the nucleus, they form what we call drug receptor complex. And after forming drug receptor complex, it commands the transcription or formation of a new gene, whereby it leads to formation of mRNA by the process known as transcription. It commands transcription, and after transcription have occurred, this mRNA moves through the nuclear pore into the cytoplasm where there is ribosome. In presence of ribosomes, this mRNA moves in the cytoplasm in the presence of ribosome and is translated to form new proteins. New proteins are formed by translation. And this is the mechanism, and when new proteins are formed, that is the response which we required. So this one is for nuclear receptors, and these ones are very slow and they do not amplify the reaction. These first three, the reaction is amplified, whereas these nuclear receptors, for them, they bind and cause permanent change within the cell by commanding formation of new proteins via transcription and translation. And we have said drugs which do better here are steroidal drugs like cortisol, hydrocortisone, drugs like estrogen, and many other drugs which are lipid soluble like dexamethasone. All of them, they have nuclear receptors causing transcription and translation to form new proteins. So this is the mechanism of action we can discuss. And lastly, we want to look at receptor regulations. These receptors, they can be upregulated. There is what we call upregulation, whereby receptors, they form or they are stimulated to increase the response. That is upregulation. Whereas downregulation, this is whereby the receptors on the surface reduce in number, leading to the reduced response, That is what we call downregulation. So you find the cells which have extracellular receptors are hidden or are engulfed, reducing on the number. That is what we call downregulation. Whereas desensitization is rendering these receptors inactive. That even when you continue to give the drug, it cannot respond because the receptors are inactivated. That is what we call desensitization. Then tachyphylaxis, for it occurs where you give, it is rapid response in case of high dose. Whenever you give a rapid high dose, these receptors can respond by tachyphylaxis, whereby immediately they reduce in number and response, and it is rapid. We are saying this reaction is rapid. It occurs at a single dose. Even at a single dose, it occurs. So long as this dose is very high, it can cause tachyphylaxis, which is characterized by reduction in the number of receptors and not responding to the drug. So you find this drug can no longer respond. Someone who cannot respond to a certain drug which they were responding due to abuse, taking it oftentimes, and then it responds. So, but this one occurs at a high rapid dose, but tolerance is the one that occurs gradually. Tolerance occurs gradually due to repeated exposures. When there is repeated exposure of a drug, you find some people who are addicted to paracetamol, they take this or ibuprofen, they keep taking these drugs. Gradually, the receptors tolerate this drug by reducing the number of that drug receptor or by rendering them non-functional. But when you continue taking, it will no longer respond to that drug. So it is gradual and occurs under repeated exposure to a certain drug, which is different from tachyphylaxis, which occurs at a single dose with rapid high dose. So this is what we can discuss in this video, where we have looked at the different mechanisms, that is for ligand-gated, for G-coupled protein receptor, G-coupled receptor. We have seen also the enzyme receptor and intracellular receptors. Thank you so much for learning with us, and we are always privileged to have you on our channel. And always remember, subscribe, like the video, and share the comments. Thank you so much.